Welcome to the Digital Healthcare Experience, brought to you by Taylor Healthcare. Subscribe now and stay on the forefront of the digital healthcare revolution.
Hello and welcome to the Digital Healthcare Experience podcast presented by Taylor Healthcare. I'm your host, Chris Civitarice, and today we're joined by Dr. William Cooper. Dr. Cooper is a practicing physician, researcher, teacher, and administrator. He leads several programs at Vanderbilt University School of Medicine, including the Master's of Public Health program, the Pediatrics Office for Faculty Development, and the Vanderbilt Health Center for Patient and Professional Advocacy, or the CPPA. And we're going to be diving deeper into the CPPA today, which supports a national professional accountability collaborative of over 200 hospitals throughout the United States and Australia with research, education, and professional accountability programs. Dr. Cooper, welcome. It's great to have you on the podcast.
Yeah, thanks for having me. I look forward to talking a little bit about what we've been up to.
Yeah, and let's start there. If you could, start by giving us an overview of your background and the current role that you're in right now at Vanderbilt, specifically with the CPPA.
Yeah, so I'm a pediatrician. I take care of children here at the Monroe Carroll Junior Children's Hospital at Vanderbilt. And I also lead the Center for Patient and Professional Advocacy. And that is work that we do helping physicians and nurses and nurse practitioners and other healthcare team members to be the best version of themselves. Recognizing that occasionally people are going to stub their toe and maybe have a bad day. And what we want to do is give people feedback because we recognize that some of those behaviors get in the way of what we're trying to accomplish in terms of taking care of our patients. And so by giving people feedback, and for those who then keep doing it and develop a pattern, we have a process to identify benchmarking for them so we can provide them national and international comparisons and give them the chance to self-regulate, because that's really what professionals do.
Yeah, it's fantastic. I'm really excited for this conversation. This is really interesting and unique work, really important work too. And I know that your work with healthcare organizations involves using their data, existing data, to identify and intervene when a pattern of undesired interactions, let's say with patients or coworkers, may be associated with worsening patient outcomes. So I'm wondering if you can dive into that. That's a really fascinating topic. So can you share how you first developed the approach and what type of healthcare professionals you're engaging with in this work?
So we really started as looking at, we were a medical malpractice research shop, right? So we were looking at why patients may sue doctors, why some doctors get sued more than others. And we just sort of had this serendipity meeting, as often things happen, where we ran across our patient relations director here at Vanderbilt, who had a list of doctors who were getting a bunch of patient complaints. It turns out it was the same doctors who were getting sued.
Wow.
And so we were able to use a model of providing feedback to them using sort of academic detailing approaches to provide peer-to-peer conversations to benchmark them and give them the opportunity to say, gosh, for some reason, my practice seems to be different than others. We had a pretty favorable experience with our malpractice here at Vanderbilt, along with other things that we did. And people started knocking on our door saying, hey, we want to learn what you've done and figure out how to do that. And from that, we've grown to this national collaborative of 200, now almost 300 hospitals and health systems around the country, where we ingest their data, we take that and identify their high-risk clinicians, and then feed that back to them so that they can give feedback and give people a chance to self-correct. The two sources of data that we receive are unsolicited patient complaints. So these are where somebody's unhappy enough with the care they receive to call an office for patient relations for a hospital, health system, or a practice and say, gosh, this didn't go like I thought it should. And when you give patients a voice, they'll often identify individual team members who created an additional challenge for them in seeking the best healthcare that they could. So those patient complaints are one source of data. We get a daily download of patient complaints from all of our sites, and we review those and look for those individuals who have patterns. We currently do that work with physicians as well as with advanced practice professionals, nurse practitioners, and physician assistants. That's been going on for about 25 years. About 12 years ago, we added an additional source of information. Because it turns out that there are some individuals who may be disrespectful towards their patients, but they're perfectly kind to their colleagues. And there's some individuals who are pretty rude to their colleagues, but very, very helpful and engaging with their patients. And so we use safety event reports that identify individuals who engage in ways that get in the way of what we're trying to accomplish in terms of our safety and reliability. And those coworker concerns get downloaded to us every day. We use natural language processing and machine learning to identify specific types of reports as well as patterns. We then feed that information back along with benchmarking and training of leaders on how best to address those. What's really striking is that when you give individuals feedback, even when they've been doing this a bunch of times, 85 to 90% of the time, they stop doing it. They get better.
That's really interesting. So in terms of, I'll say the resistance to that feedback, what you're finding is that when an issue is raised, there seems to be a pretty good level of receptiveness to hearing that and correcting it and kind of improving going forward.
Yeah, we give space for people to be defensive and to say, this is, there's obviously, this is not my fault, it's somebody else's fault. And we actually provide training. We've trained thousands of messengers around the country on how to have non-judgmental, respectful conversations that give people a chance to say, I think that, the system's broken and that's why I behaved in that way. And I'll say, yeah, I get that. And when you tell someone they're stupid because they can't do their job very well, then that may get in the way of what we're trying to accomplish both in our culture and in terms of delivering the highest quality care.
Yeah, fascinating that you're sort of working on both sides of that aisle in terms of the data and then also on the communication side. I know we're going to talk a little bit more about communication in the coming parts of this episode, but I want to go back to, you were talking a little bit about basically how you started with malpractice, how you started with patient relations data. I'm curious about the evolution in terms of how that then developed and fed into the proprietary algorithm that you've created. So what kind of risk factors are you looking for? You mentioned some of the data sources. Are there other data sources out there that you're relying on to make some of these assessments?
One of the really interesting things that we've been able to do is, in addition to the services we provide through this national collaborative, we've also been able to do a little over 150 research studies using these data to help understand. So the early work in medical malpractice included information about the specialty type and the subspecialty type and the sex of the physician at that point, as well as the place where they worked, the type of environment, their productivity, and their patient complaints. It turns out when you look at malpractice, patient complaints are the strongest predictor of malpractice claims by far over those other factors. Those are important things, but they give us really great insight. We've extended beyond the malpractice. When I started, I've been a part of the center. I was a messenger, so I was having these peer-to-peer conversations for probably 15, 20 years now, since early on in the center. When I took over running the center from our founder, Dr. Jerry Hickson, we've added additional types of studies where we've linked these professionalism concerns from patient complaints or coworker concerns to surgical outcomes data. And we found a significant association that patients whose surgeons have a large number of patient complaints have a 25% increased risk for having a surgical complication, a surgical site infection, a pneumonia, anything that is getting in the way of their healing. In a similar study, we looked at coworker concerns in a totally separate analysis and found a very similar association. We also know that these types of behaviors are affecting nurse turnover and physician turnover and retention. We also know that when you think about physicians who behave unprofessionally towards their coworkers, they sometimes are also disregarding safety procedures like procedural timeouts. Like following bundles of care that say every time we do this type of procedure, we're going to use these types of antibiotics. We're going to treat the blood sugar in this way. We're going to do very specific things. These same physicians often disregard these safety and quality things, even hand washing.
Wow.
And so what we found is that when you can give feedback and help just a little course correction, it helps not only that individual's performance, but also the performance of the team.
That's really fascinating correlations there. And we'll talk more about that too. I want to go back to another element that you mentioned just a bit ago around natural language processing. And obviously NLP, now plays a role in identifying, as you say, specific risks of, language in patient and coworker reports and so on and so forth. So I'm curious, can you explain how NLP actually helps you now pinpoint potential issues before they may even escalate?
One of the really important things that we've been able to recognize is that there are some specific types of behaviors described in these patient complaints and these coworker concerns that may require immediate intervention. Things like sexual boundary violation, impairment by drugs or alcohol, cognitive impairment, discrimination or bias, violence against a patient or against a coworker. And so the process, our algorithm includes ingesting these data and really understanding. But the first thing that we do as we ingest a set of data is use NLP tools to identify whether a report contains any information that suggests that it might be one of these sort of really serious, important events. So we do that on a daily basis as we ingest our data. That gives us a chance to pull that out and confirm whether or not the event has been addressed already, the nature of the event, the individuals involved, and then we have a daily feedback loop back to our sites where when we identify one of these, we say, hey, this may be a report that might require special attention. We thought you'd want to know about it. We've identified threats for gun violence that actually had not yet been picked up by the local site. We were able to call them at 5 o'clock in the morning and say something may be going down in your area. And that gave them an opportunity to get ahead of that really potential disastrous event. We've identified opportunities where there are sort of progressive behaviors that may be of concern. So as opposed to sort of the overt sexual touching or something, things that begin to escalate and are sort of what you might describe as creepy behaviors or engaging in ways that are sort of continue to escalate. We'll identify, pull those out, confirm them with our manual coding, and then get those fed back in.
Fascinating work there. And it's amazing, sort of using NLP as the technology sort of at the root of it, in terms of, the language, the words, the diction, all that sort of feeds into that outcome. That sounds like a really novel approach. It sounds like that's very unique in terms of the work that the CPPA is doing. Is that fair?
It is unique. We have a unique opportunity because we receive these data and we work closely with our sites and provide not just data processing, but also support for them and leadership. I get on the phone pretty regularly and provide leadership coaching on, okay, here's how you might navigate that. And then they make their own decisions locally. But I say, similar organizations who are in this position sometimes have taken this approach. But what's fascinating is that we also have learned with our approach to NLP is that each site has very unique characteristics. So you think about a hospital that may call their trauma unit, quad 4, right? And so everything that references quad 4 is not going to be consistent across different sites.
Right.
And so what we create are individual site-specific algorithms. We then create aggregate site algorithms. And because we do manual coding and confirmation on the back end, we're also able to assess for drift in our models over time. Because we use NLP to also look for events that may have a little higher yield than other types of reports, because we process hundreds of thousands of these things. And so the ability to use that to target and then to do that. But we've sort of understood that in that drift, we give a chance for course correction by regularly assessing sort of what's our hit rate. Is it about what we expect it to be? And how do we account for some of those site-to-site differences?
Interesting. I want to go back to the notion that you mentioned earlier in terms of poor communication between providers and patients being associated with worse outcomes. And you cited particularly surgical and trauma cases, things like that. I'm wondering if you can give us a little bit more about that. Are there any specific insights, case studies, highlights, things like that would go a little bit deeper into that correlation?
So you think about it like physicians who behave in disrespectful ways or even just disregard for their patients, there's a breakdown in that trust. So if I have in my pediatric practice, if I have an interaction with my patients where they perceive me to be dismissive of their child's complaints, and I say, yeah, here, I'm going to prescribe this medication. If they don't have a connection to me, they're less likely to be adherent to the therapy. Yeah. In addition, what we find is that these types of things pick up on a broader array of potential unprofessional behaviors. So, for example, many hospitals will have on their nursing units various protocols designed to improve patient safety and quality. For example, when somebody has a urinary catheter in, they may have a protocol that says, okay, on this day when these characteristics are met, the nurse can remove the Foley catheter or the urinary catheter, and that reduces the number of urinary tract infections. Well, if you've got a physician who comes on a unit and says, who the heck removed my patient's urinary catheter? Yeah. The last time I checked, RN does not equal MD. Right. It's a real report, by the way, right? So these are things that happen. The examples I provide are real reports that we have processed through our center. But when that happens, you can see that the next time that nurse or other nurses on that unit go to follow the protocol, they may hesitate. And eventually, the number of times that happens, they just stop doing it altogether. So you can see where that begins to play out. And it's both, what's interesting is it's signaling the coworkers and in the patient complaints, independent assessments. What's even more interesting is the effect of teamwork on patient outcomes. We did a study with 70,000 trauma patients from 10 different level 1 trauma centers around the country who are part of our collaborative. And we were curious about whether we could measure team professionalism. In this case, we used patient complaints. And we looked at every service. For every one of those 70,000 patients, we were able to identify, using National Trauma Data Bank data, whether or not a particular specialty cared for them at that site on the day of their injury. Right? So we were able to say, okay, you've got emergency medicine doctors, you've got anesthesiologists, you've got neurosurgeons, orthopedic doctors, and trauma surgeons. So 5 different services. We took each of those services and compared them nationally to see whether a larger proportion of each of those services had doctors with unprofessional behavior. So we benchmarked neurosurgeons to neurosurgeons, ED docs to ED docs. By doing that, we were then able to say, this patient may be a little higher risk because they've got one or more teams who have high rates of unprofessional behavior, because we know individual surgeon behavior is associated with outcomes. Well, turns out having one team with a higher than expected number of docs with unprofessional behaviors increased the patient's mortality risk by 24%. They were 24% more likely to die from the injuries.
My gosh, I mean that's pretty striking. And I mean the line that you draw from the initial sort of, I'll say seeds of that miscommunication, of that, unprofessionalism, what have you, all the way to, I mean, a 24% increase in mortality rate. That is I have to imagine when you start to analyze those data, that became pretty striking.
It was. And what's really interesting is that in the work, as I'm an epidemiologist, and so I'm trying to understand these things in addition to really thinking through this. I would just ask a trauma surgeon, I'd say, tell me, what the heck is happening here? And they would say, well, that service, and they would sort of pick a service at their place, and they would say that service, they all hate each other. They don't get along with each other. They compete for resources. They are really difficult to work with. And there's one of them, Dr. McNasty. I got to tell you, Dr. McNasty is particularly troubling. And what the ED docs and the trauma surgeons told us, they say, if Dr. McNasty is on call for this service, I just wait until they rotate off.
Wow.
Like, okay, I mean, like 10 different surgeons at 10 different places told us these stories, right? So this is not a single place. I said, well, let me just make sure. I followed up. I said, God, tell me a little bit more about this. So you've got a patient who has an injury, right? And they may have a Foley catheter in. Let's say they've got a pelvis fracture, right? Which increases your risk. The longer that catheter is in, the longer you're likely to have a urinary tract infection. And we don't want that to happen. So, but what you're telling me is that you let that sit for an additional day or two. because it's so challenging. They said, no, we don't just like the patient language. We treat other injuries, but we just sequence it so we don't have to deal with that. Well, I get that. But you can see then how that begins to play out, because what's happening is the behaviors of that individual and that team are affecting not just their team, but how others interact with them and how other teams treat their patients.
Really fascinating. I want to go back to the feedback sort of part of this equation. And we talked a little bit earlier how significant that peer-to-peer feedback is in terms of your approach. So can you talk to us a little bit about how presenting the data from a colleague helps encourage self-correction among healthcare providers and things that have worked really well in terms of providing that feedback to peers?
One of the basic tenets of being a professional is self-regulation. As a pediatrician, when new guidelines come out for how to treat pneumonia, I look at my practice. Here I'm doing this type of thing. Here's what the new guidelines say. And what do I do as a professional? I self-regulate and align with my peers. The same thing applies with how we treat our patients and our coworkers. So our approach is we actually start early with peers, right? But when we get a single event, we dispatch a messenger. Let's say we get a coworker concern. We dispatch a messenger, and we do this work now, I'll tell you, with nurses, nurse practitioners, doctors in training, attending physicians, PAs. We're starting with surgical techs, and it's the same exact experience. I put a nurse with a nurse, a surgeon with a surgeon, a non-surgeon with a non-surgeon, et cetera. We train them on how to have the conversation. In that first conversation, when we get a single event, we call it a cup of coffee because it's the lowest level of conversation. It is intended to be informal. Hey, I just want to kind of let you know that, how are things? We first train them sort of on empathy-based approaches. How's it going? Sounds like that was a stressful call night last night. Tell me a little bit about it. Now, they may describe the event to me, and I'm going to say, I hear what you're saying. That sounds like that was pretty stressful. And the fact that that nurse called you 4 times was probably frustrating. I can understand that. Now, is there any way that your response could go differently? Like, for example, when you said, don't call me again with these stupid questions. I'm just curious, is there another response you might have? That cup of coffee between peer to peer is actually 97% effective. Just a single event doesn't happen again if we get feedback to them. And this occurs here at Vanderbilt. 95% of these get delivered within 2 days.
Wow.
I've got 300 trained messengers. We have a system like clockwork. We get it out. They let us know that they delivered it. It's confidential. We don't tell a bunch of people about this. We just use this as a part of our peer feedback. Now, when they develop a pattern, meaning they've got multiple reports, and our algorithm is based on both recency and severity. So we in the background are calculating sort of what we call an index or risk score, where we're looking at more recent and more severe reports counting more or weighting more than older and less severe. And the algorithm moves forward and updates so that old reports fall off and new reports come on. So I can track whether a score is increasing or whether they're getting fewer reports and now that score is decreasing. I can then give them feedback and say, great work, things are better. But when you get to that threshold, and the threshold is a 3-fold increased risk for malpractice. It's a risk for surgical complications. It's a risk for well-being concerns like cognitive impairment and burnout and other things that we've been able to study by showing when you cross that threshold, there's a lot of things that we want to help prevent. In that awareness, what we call an awareness conversation, it's a cup of coffee, single event. Next level up is what we call an awareness conversation. And in that, what we do is we then benchmark them. We say, hey, I wanted to let you know that you have a really important practice here. And because these are peers, I can say, and I refer patients to you all the time because you're an outstanding pulmonologist, or you're a great cardiologist, or a really wonderful gastroenterologist. Now, for some reason, when we compare you to other gastroenterologists, both locally here as well as nationally, we've got 150,000 clinicians in our national data set. I can show you a dot on a curve where you compare to 4,582 obstetric gynecology doctors. That then is a powerful notion because it gets rid of them saying, well, you don't understand, I am insert their specialty. My practice is special. My patients come to me in pain. I'm really good at what I do. So I get the most complex cases. And I'll affirm that using our empathy-based training to say, yeah, I hear that. And that's really why I'm here, because you really are a good doctor. But I wanted to give you a chance to understand that for some reason, I don't know why it is, but for some reason, when we look at your practice, it's different than your peers. The work they do doesn't happen in that conversation. So I don't require them to sort of have this sort of remorse or this great, okay, fine, I'm going to get better, because I know that 87% of the time, they're going to drop their numbers of coworker concerns or patient complaints. But if they don't, we're ready. So if we continue to calculate the score, and if the score increases, we move up what we call our professional accountability pyramid. So cup of coffee, awareness. Now we go to a step up where your boss is now around. So it's been peers up to this point. Now your boss is getting involved, because there may be systems things that are getting in the way of your ability to improve your professionalism. Your clinic may be understaffed. There may be things where they're getting the wrong trays to the OR repeatedly, which is leading to your great frustration. There may be a variety of reasons for that. But it also may be that your boss needs to kind of help you get the right resources, but also convey to you, you've had every possible chance to self-correct. We've given you individual cups of coffee. We've given you an awareness intervention, or maybe even two. But now it is my expectation that you're going to improve your performance. These are typically still informal conversations. This is not disciplinary action. Now, we are moving closer to that, of course. But these are informal conversations where, in a respectful way, I'm just going to say, gosh, I need this to get better. I will help you. I will get you coaching. I will get you a well-being evaluation. I will adjust your practice. I will make sure we hire the right people. But I'm going to count on you to take ownership of your part of this. And I've had, as a leader here, I'm an interim department chair, and I've been a vice chair. I'm in our department of pediatrics. So I've had all of these conversations over the years. And those are they're hard conversations. It's stressful as a leader to know that for whatever reason, someone is really struggling to address these professionalism concerns. But what's really rewarding about it is I'm confident, even at that level, when we put a corrective plan, that authority-guided intervention, there's still an 80% chance that things are going to improve.
Wow.
So out of our tracking of 150,000, almost everybody gets better. I got a patient complaint once. I'm in that pyramid. I got feedback about an interaction I had with one of my patients. It was November 14th, 2002. I still remember it. And it was over antibiotic prescribing. We were beginning in that era to prescribe fewer antibiotics for ear infections. So I was like, okay, I'm going to do this. And I'd actually even attended a collaborative decision-making conference the week before. And I was like, okay, I'm going to talk to this mom about this antibiotic, and I'm going to do this, and I'm saving the world. And I was a sort of enthusiastic young faculty member. This is going to be great. No more antibiotic resistance. Yay. So I did it. So I walked out. I was like, this is really wonderful. I forgot the grandmother. So the mom got home and said, okay, we got a plan with Dr. Cooper here. And the grandmother said, no, we need to go to Walgreens and get this amoxicillin filled. And the mom said, well, Dr. Cooper and I talked about this, and we agreed not to do that. And so the grandmother was really unhappy. She picked up the discharge papers. I'll never forget the message I got. She called Vanderbilt. She said, I don't know what kind of idiots you're hiring, but Dr. William O. Cooper appears to be your chief idiot.
Oh, gosh.
That hurt my feelings, right? I mean, I wasn't thrilled to get that feedback.
Sure.
But it gave me a chance to reflect on the fact that when I have those types of conversations where we are adjusting our practice for prescribing antibiotics, I need to understand what else may be going on in that home environment. So now what I do is I say, hey, we're not going to prescribe antibiotics today. Let's agree to this. Who do you stay with? Let's call them. So I'm still here. I'm doing fine. I was not thrilled. I wasn't like, oh, this is great. I love getting negative feedback. But it gave me a chance to adjust my practice. That's what this is about, helping people be the best version of themselves.
It's really interesting. I think we could probably do, a whole episode on your methodology of providing feedback, because it sounds like a lot. Obviously, a tremendous amount of work has gone into sort of the data side of this, the analytics side of it. But it also sounds like sort of commensurate work has been done to make sure that it's sort of heard and received well, and changes actually take place. So fascinating to hear the conversation around feedback and all that you've created around it. And as I say, that could be another whole episode sort of in and of itself. But I'd like to also get back to the notion of the results that you all are seeing over there. So 85%, reduction in malpractice risk within an orthopedic group is one statistic that I've heard. We obviously have many things that we can sort of point to. But I'm wondering, can you tell us more about that particular study and what led to such a significant impact in that one particular event?
Really interesting. So there've been other analyses we've done. That most recent one we did with a large regionally based orthopedic group, and we were able to identify, using the patient complaint data, their highest risk doctors. So we gave that information to them. They addressed them. But what was interesting, and this is really where you begin to the work takes hold, they recognized that how every one of their doctors treated their patients was an important part of their success. And so they included, here's how we expect you to behave towards patients when you're a part of our practice. They included it in their onboarding. They give regular feedback to their doctors on that. They are not afraid to have difficult conversations and make difficult decisions about individuals who don't improve. This is not about firing people at all. In fact, at the very top of that pyramid, out of 150,000, there's 138 people, 150,000, 138 who didn't improve at all in our national experience. And that 138, 5 had previously undiagnosed brain tumors. 25 had early signs of cognitive impairment. So if you don't get better, there's something going on, and I need to understand that as a leader. But back to this ortho group. What they did is they included that in their leadership development. They included that in their onboarding. They included that in their expectations. So not only were they able to address their high-risk docs, and they continue to, it's not uncommon to continue to identify physicians through the patient complaint work over time, because people join the practice, people develop burnout, well-being concerns, people have stressful life circumstances, all sorts of things. And so that ongoing surveillance. But so they were able to address their highest risk docs, but they were also able to do, on a preventive side, individuals who started early on with just those early cups of coffee or those awareness interventions. And so every one of the doctors who got identified dropped their malpractice risk by 87%. So you could picture that they're generating a disproportionate share, but they also dropped their overall group's malpractice risk by 87%. Wow. We've done these similar analyses, 12 to 15 different places. It's very, very similar. There's a group out of University of Pennsylvania that did an independent assessment of their work that they published in the literature, and they found a 50% reduction in their malpractice risk overall. Now, these are in concert with several other things. So identifying the professionalism concerns isn't the only thing that you do. We do a lot here at Vanderbilt to reduce, and we've had a very favorable experience. But it's around this idea, is that recognizing that you've got to address intentionally designed systems and the people who work in those systems. That balance is a key part of our work.
Really interesting. As you think about sort of where we go from here, obviously, I mean, with the results that you're seeing, I have to imagine that we're going to continue to sort of grow in this space. And as other healthcare leaders are looking to adopt similar strategies within their organizations, through the lens of both patient outcomes, malpractice risk, all the sort of drivers that you talked about, what advice would you give those healthcare leaders that are looking to adopt what has been such a successful program here to date?
I'll tell you, it's got to be rooted in your values. You have to know where you're heading as an organization. And when we're onboarding a new organization, the first question I ask, I'll sit in the CEO's office, I'll say, what does this place want to be when it grows up? And I listen to them, but I also go and I ask a nurse at a check-in desk, what does this place want to be when it grows up? And I'll ask a physician, what is the place? I'll ask mid-level leaders, ask everybody. And what happens is that if they all answer the same thing, that place is ready to go.
Sure.
If they're not sure, we'll say to them, there's some work that needs to be done, because you have to know where you're heading. And you also have to be unequivocal in your declaration. it means something to work here. Being here, we're going to hold each other to a certain level of accountability. Being our commitment to excellence, our following guidelines, our treating our patients with respect, our treating our colleagues with respect. And so that sort of idea of clearly stating the values, having an unequivocal commitment to accountability, but then also making difficult decisions. And that difficult decisions isn't separating people. That's not what this is about. What it is about, though, is the saying, it means something to work here. And I do care deeply that you generate a lot of revenue for us. I do care deeply that you have a strong relationship as a nurse who provided care for one of our board members. I do care deeply that you are in an academic setting, a highly productive researcher. And I also expect you to treat your colleagues with respect, just like I expect that first day physician or nurse who just joined our organization yesterday. That values, that unequivocal statement, and that willingness not to blink, we call it. Like, so if I blink because of your special status, those are the things that are absolutely essential to be successful in the space of professional accountability.
It's amazing. And I think that that advice probably transcends, the clinical care space, the hospital space, the healthcare space as well. I think that is so true, probably for every single walk of life or business or what have you, in terms of trying to, drive change and drive better outcomes. So I think that is just a really wonderful observation and piece of advice there. Curious, anything else as we wrap up that you're interested in sharing with the community? Anything else that you're working on that you're excited about? Anything at all in terms of last thoughts here, Dr. Cooper?
One of the things that we've been really struck by is how consistent the model works no matter what's going on, right? So we started with physicians. It worked. We added nurse practitioners. We added nurses. We're adding surgical techs. And the distribution's the same because the vast majority of individuals never have any of these events, right? That's the key thing, right? 90% of individuals go about their work, never get any. I got that complaint in 2002. I haven't gotten a lot since, right?
Right.
So what we're after, though, is that small number who account for a disproportionate share.
Right.
And so the fact is that this works with people, right, whatever their profession, but also works in Australia, it works in New Zealand, it works in Singapore. Anytime you've got humans together who are trying to do the right thing by patients, we have to give space for people to sort of have occasional hiccups.
Right.
But ultimately what we're after is to, as many days as possible, allow each of us to be the very best version of ourselves. And I'm going to commit to giving you feedback when for some reason that doesn't go like we expected. And that's what's so rewarding to me about this work. I love what I do. I can't wait to get to work every day because it is an opportunity for us to make such a difference in a really important area because people want to come to work and do great work. And what we need to do is help them do that.
It's amazing work that you all are doing. And obviously the results really speak for themselves as well. I really appreciate you joining us today, Dr. Cooper. It was a real pleasure to have you on.
Well, I love talking about this stuff. So thanks for having us. And it's really been a great conversation.
Absolutely. I hope you come back and update us on progress and all the things that are coming. So again, really appreciate it.
I'd be delighted.
And thank you also to our listeners. If you enjoyed the conversation, please like, share, and subscribe to help us keep growing the show. And if you'd like to learn a little bit more about Taylor Healthcare and the digital healthcare experience, you can go to taylor.com/digital-healthcare. That's our show for today. And until next time, I'm Chris Civitarice, wishing you health and good cheer. Take care.
To learn more about Taylor Healthcare, please visit taylor.com/digital-healthcare. This podcast is for educational purposes only and is provided with the understanding that it does not constitute medical, legal, or financial advice or services. The Digital Healthcare Experience is produced by Naomi Schwimmer. Podcast music by Nicholas Bach.
Informed consent is vital to patient care, but how can you help patients make informed decisions? Introducing iMed Health from Taylor Healthcare. Digital tools that standardize and simplify the informed consent process. Go to imedhealth.com to learn more. Find the link in the show notes.